Welcome everyone. As you're joining, go ahead and just add your contact information into the chat and we'll get started now. Awesome. So as you just heard, we are recording this echo session for educational and quality improvement purposes. So by participating in the session, you are consenting to be recorded. And if you don't wish to be recorded, you can just disconnect from the session now. Participation. So ECHO is an interactive community. So we have presenters, stakeholders, and community members all on the call. And so we just ask that if you guys have questions or if you guys have any comments or anything, you can feel free to come off mute or you can just put them in the chat. And one of our hub members, Kurt Phillips, will be monitoring and he'll call out your questions when you have them. So we do ask that you protect individual privacy. So we do discuss like cases throughout the session, especially during our case presentation. So just avoid using the real first, middle, or last names. And if you have any questions about this, you can reach out to a hub member and they should all have asterisks in front of their names. So key components of an echo session, we usually have a didactic speaker to start out. And then at the end, we will have a case presentation and we'll go into breakout rooms to discuss recommendations for the case presentation. So, and then of course, we just have the professional networking throughout the call. That's why we ask you to put information in the chat and then just be participative. And then renaming your profile, you can just rename it to your first and last name, your state, your job title, and your organization. And that just, again, helps with the professional networking. And then there's the raise your hand feature. If you have a question, like I said, you can put it in chat or you can use this feature. And once again, like Kurt Phillips will call it out or one of me or Leo will. Pre-registration. So you are welcome to pre-register for our echo sessions, and this will allow you to receive materials in advance. So you can do that by emailing our projectscope@usu.edu. And then to get a credit for attendance, we ask that you fill out our survey. Leo and I will be dropping that in the chat throughout the session. So just go ahead and fill that out. And in about a couple weeks, you will receive your credit for attendance. So Canvas is where we store most of our information. We put our session recordings, we put our presentation slides and case presentations and recommendations all on there. So if you wish to gain access to that, you can just once again email our project scope email right here. And then case studies. So at the end of the session, we'll have our case study, like I said, and this just shares information about real life situations. So if you're interested in sharing a case, this is like a really good opportunity to get lots of resources and recommendations from just a whole group of professionals. So we'd highly recommend sharing a case study if you need help with anything. And these are our social media pages. We have Facebook, Instagram, and LinkedIn. So we just kind of put our updates on there, upcoming sessions. It's just a really good way to stay in the loop with Project Echo. So, and then we do have our Facebook group. This just allows us to continue the discussions after the sessions. So every month we'll post a monthly discussion question. And if you guys ever want to ask a question or start a discussion, you're welcome to on this group. So. Awesome. So I think that's it. And I'm just going to turn the time over to Matt Huntington. He's from the Tooele Opioid Response Network, and he's going to be talking to us. So you're welcome to share.
Thank you, Shayna. Thank you for inviting me to come and share some of the programming that we've been doing. I will pull up my slides here and we'll get started. When I created this presentation, the intent of it was to be interactive, and I know that's hard to do over Zoom. And maybe, Kurt, I'll have asked for your help in reading out some comments as I'm going through the slideshow or the slides. Okay, so I work for Utah State University Extension. If you're not familiar with the extension model, the high level view of it is that extension is in almost every county in Utah. And their objective is to bring resources of the university to the community. We have a number of different programs, probably most well known for 4-H youth programming and agricultural gardening type programs. But there's so many programs out there that USU Extension does. And I know that my colleague, Tim Cady, who's on the call today, presented last time the HEART initiative, or the health and wellness piece of Extension, began maybe 7 or 8 years ago. And so I am a part of that group, the HEART group, the Health and Wellness USU Extension. And I have an assignment in Tooele County and also in Salt Lake County. And all of the programming that I do is related to overdose prevention, substance use disorder treatment, recovery, those types of activities and programs. Okay, so today, one of the big goals of this presentation is to talk about partnership building. So as you could see in this slide, we're talking specifically about jail-based substance use treatment and how we were able to make a partnership with the jail to bring programming into the jail. But I think this is also useful for maybe any partnership areas that may be difficult to make partnerships with. And so that's kind of the lens through which I was looking at this, and the process of addressing needs of a target population through partnerships. Okay, so before I get into that, Shana also mentioned that I'm a member of the Tooele Opioid Response Network, and I want to talk about that briefly. The Tooele Opioid Response Network is a consortium, a coalition that USU started about 5 years ago, and it was under an objective from a federal grant through HRSA. And we wanted to harness what everybody was doing in Tooele County and come together and collaborate. And so I just wanted to kind of show the success, any successes that we've had in Tooele County has been because of the Tooele Opioid Response Network, or TORN is what we call it. Here are the members of TORN. I kind of tried to categorize them, based on their primary objective. But we have recovery communities, local service agencies, clinical partners, and first responder partners. Probably the most important thing here is of why this coalition has been effective is that the key players are involved, like the health department, the sheriff's office, people who with lived experience from the recovery community, the human services. So it's been really rewarding to work with this group of people. And in fact, they're having a meeting right now, so it's live and well. I also wanted to just show sort of the general menu of different programs we've worked on as a coalition. And most of these have been sort of USU led, or I don't know if I want to say led, but USU has been sort of the instigator of starting some of these, and then really through the support of TORN members, they've been carried out. So you'll see a number of different things there. Not all of them are current. I kind of view our role in Tooele County as trying to expand resources where there aren't any. So identifying gaps in services and trying to bring in resources through grant funding. And also sort of pilot testing out different programs to see if it meets community needs and if the community finds them effective. So those are the different categories of things that we work on: community education, professional education, partnership building, and then service expansion through partnerships. Okay, so step one of finding and addressing needs, developing programs, and meeting community or population needs through partnershiping is identifying your target population. So what does a target population mean to you? It's something to think about. When I think about a target population, there's a few different considerations that go through my mind. One is what are the programs that are available to you as the provider of a service? What programs do you provide, and do they meet the needs of the community? Then, of course, I think the most obvious way to think about target population is by need. You know, who is at the most need? Or me coming from a public health background, whose health outcomes may be the poorest? You know, who needs the services the most? Also, as a provider of services, are the services that you offer accessible, or do you have the capacity to serve this target population? And then responsiveness, how will the target population, you know, respond to the programs that you're offering? All right. This is sort of strange because I can't see anybody or any of your faces or your little icons or anything. So Kurt, I think it's Kurt, right? I'm gonna rely on you for some help through the chat. Is that all right?
Sounds good. I'll keep an eye on it.
Thank you. So the question to the group: how do you identify target populations? What do you do to find those communities that are in need? I'll just give you a minute to think about it. You can either come off mute and talk, which is great, or if you want to throw a message in the chat, Kurt will read it out for us.
So Matt, Tim Keaty says to research local communities.
Yes, research. So Tim, can you say a little bit more about what you mean by that?
Yeah, I think that, you know, what we do is we look at what population do we want to work with, and wherever might the needs be. So we have an assumption and we want to prove or disprove that that's going to be correct. So we start asking people what we can do, or looking up the data that's available that other people have worked on. We do a lot of stuff with the Mountain Healthcare,
Yeah.
River Health Department, those kind of groups to find out what the populations need.
That's a great point. And when you're talking, Tim, it made me think that a lot of times when identifying a target population, especially in rural areas, or if it's a population that faces a lot of stigma from like public access, for example, people who use drugs. Sometimes you'll identify your population as you're implementing your program. Sometimes you won't know exactly how to access a population. But here are a few things that I thought of. I thought of it in terms of external and internal, internal being USU. So externally, for me to identify target populations, I look at the Utah Public Health database called IBIS, SHARPS data, which is a school-based behavioral health big data collection effort, is another great one if you're looking especially for youth programming or trying to identify what youth may need program and access to services. Tim mentioned this, but local health departments or other industries that are already collecting data, like he mentioned, the Intermountain Healthcare. Just general literature review. There's other states and there's national data. There may be international data if that's relevant to you. Internally at USU conducts a statewide needs assessment that kind of helps guide USU Extension to know what community members value in programs. And then we also do a lot of community surveys. So we run community events, and everybody who attends, we offer them the chance to sign up so they can hear more about what we're doing. And we'll ask them for their feedback on things. And then the last one on there, a coalition or a committee, is a little less formal, but they're very, very impactful. And I'll talk a little bit more about how we use that. And that was mainly through TORN. Okay, I'm going to talk to you a little bit about Tooele County. Tooele County is just west of Salt Lake City. It is geographically very large. County. The jail population there is about 207 people daily average. Currently, Tooele County has the 7th highest opioid overdose mortality rate. When we started this project, they kind of bounced around between 2nd highest to 4th highest, but now they've dropped a little bit. The mortality rate in Tooele has pretty much stayed the same. I think it's actually gotten a little bit worse in other health districts that it's been compared to. So I'm just giving you a little background on what some of the issues are that people are facing in Tooele County. 22% of Tooele. Go ahead.
Just real quick, and Lindsay put in the chat, if you're looking for needs of youth, the local CRCGs are a great place to start.
Cool. Thank you very much, Lindsay, for throwing that in the chat. So many of you are likely familiar with adverse childhood experiences. It's just a tool that's measuring trauma that the individuals face during childhood. And in Tooele County, 22% of Tooele residents have had 4 or more adverse childhood experiences, or ACEs, and that's highly correlated with substance use disorder. So we are also looking at recidivism, which is returning to incarceration after being released. This is an important part of our program as well. They estimate the national recidivism rate, 3-year recidivism rate, at 27%. And in Utah, they estimate it to be 17%. If you go and search for these statistics, they're going to vary pretty widely. I've seen some estimate up to 50%. That just gives you a rough idea. When we are also looking for our target population, again, when we began our programming, we based it off a lot on this data that we found. And so the gray is opioid overdose deaths, and the red is treatment options. You can see Tooele County at the bottom there, that they had a high overdose death rate and the fewest treatment options. So that indicated to us and to USU, when the Health and Wellness Initiative began, that Tooele was a county to focus on. This data came more from a generalized literature review. So when compared to the general population, people leaving incarceration are 10 times as likely to have a non-fatal overdose and 20 times as likely to die from an overdose when compared to the general population. And this risk is especially high within the first 2 weeks of individuals leaving incarceration. I really, really wanted to find Utah-specific numbers, and I did the best I could. I don't want anybody to use this statistic because it's not officially published. The data that I was able to find wasn't the greatest, to be honest, but is the best I could do. And it was provided by Utah Department of Corrections, and they were estimating what overdose was like when people arrived in incarceration and when they left. But still, it demonstrates that people in Utah leaving incarceration are more likely to die from an overdose when compared to the general population. So that's important. It's important because when we started this programming, we wanted to identify a target population within Tooele County. So this is an overview, high-level overview of what I just talked about. So 1, we knew that Tooele County had a high overdose rate and that they had limited treatment options. And below that, you can see where we got that information from. We knew that they had high risk factors for substance use, like ACEs. We knew that in general, there's a high overdose risk for individuals leaving incarceration. And then the last one, through hosting the TORN coalition and making these partnerships and having these conversations, these informal conversations, we were able to understand that there was very little jail-based programming happening in Tooele County. All right, so when thinking about your target population, I want you all, actually before we get to this, I want you all to think about a target population that perhaps you're already working with, or one that you would like to work with. And when we go through the rest of this presentation, to think about that group specifically and potential programs or partnerships that you could create to serve that population. So I'm going to give people a minute to answer that question in the chat. So what is a target population you already serve, or a new population that you're investigating serving, that you would like to serve? I'll give you a minute and then we'll rely on Kurt again. Thanks, Kurt.
Fearless says the homeless.
Okay, people who are experiencing homelessness.
Cache County Jail and the unhoused, Tim says. Elizabeth says mentoring the youth.
Okay, awesome. Thank you for being willing to share. And I think that'll just make this more useful when you have a target population in mind.
There's also a couple more in here.
Yeah, go for it.
One is basic needs services. The other says rural or frontier areas.
Cool, great. And you'll find that within those populations, the more specific you can get, the more helpful that'll be. And oftentimes that happens through implementing programs and kind of learning what the needs are and what your organization is capable or has the capacity to do. So when you're thinking about those populations, I want you to define what your role is in helping your target population. I put on here a few examples of different things that USU is involved in. USU Extension is involved in regarding what our role is in the community. I really enjoy working for USU Extension because we have this latitude, to move around and meet community needs and to try and expand services that may need expansion or that aren't there, to see if they're effective and useful for the community. So what was our role at the Tooele County Jail? Education. USU Extension is focused on education. So education for inmates, jail staff, and first responders, and SUD involved organizations. SUD stands for substance use disorder. So when you see that, that's what that means. And then capacity expansion. Capacity expansion is a really important one, and that will be one of the main focuses here, because we know that at USU Extension, our primary role is education, but we have the ability to bring in resources largely through grant funding and to expand the capacity of our partners, because we want everybody working where they should be, right? We want everybody working within their scope. And so when we were starting this program at the jail, we knew that we would be helpful, but we knew that we weren't the long-term answer for providing substance use disorder programs in the jail, in our scenario in Tooele County. All right, so the third step in this is identifying key partnerships. Who in the community serves your target population? Outside of you, outside of your organization that has identified this target population, who else in the community serves that population? And those are the partnerships that you want to be forging. Right? So I put on there a few examples: public institutions, or maybe specific industry, community organizations. There's lots of different ones from what was mentioned as far as people who are experiencing homelessness, or youth, or people who are incarcerated. There's a lot of partnerships possibly there. So for us in Tooele County, you can see there are a list of partners that helped us to develop the jail-based programming. And there's quite a few there. And then the key partnership, of course, this one's pretty obvious, was the Tooele County Sheriff's Office, who is managing and running the jail. I also wanted to spend a little bit of time talking about effective partnership building. So for me, there's lots of different ways to look at partnership building. and there's lots of good recommendations out there. And for the purposes of this presentation, the way I'm looking at it is very simple, and the key to any partnership building is trust. And to me, the key components of trust are priority and capacity, and I'll explain what I mean by that. So for priority, it is, does your priority of someone who's implementing a program match your partner's priority? And along with that, does it match the community's priority? Right? Because you may have a great program, the best program that has worked other places. And if you come into a new area and you try to implement that program without building these partnerships, it may not work, right? It may not work before having established trust with your partners, despite it being a great program. So when I think about priority and aligning priorities, it's important to look at programmatic mission. So what's the mission of your partners? What's your mission, right? What's your role? How well do those align? And in that overlapping space, what can you do to support each other to serve your target population, right? Because like I said, everyone will have a distinct role, and that's important. We don't want to all be doing the same thing, but there's a lot of overlap. And so it's important to identify where that overlap is in the mission. Also looking at their partnership's willingness, their willingness to engage in a program that you're wanting to deliver to your target population. And also timing is a really important consideration, because you may have a program that aligns with your partner's programmatic mission, but the timing might not be right for a variety of reasons. And so one of the big pieces of advice that I would offer is, when trying to serve a target population through building partnerships, is to play the long game, like to be patient and to be willing, if you can, to build that partnership over time. And for us, I think that the jail programming that we've done can still be improved, but to get to where we are now, it took us 5 years. The other important thing is capacity, and I know, or I'm imagining that you would all feel the same way if someone came to your office and said, I'm running this program, I'm running XYZ program, and it's a great program. And then you think, wow, XYZ program is amazing. Like, I love XYZ program. It aligns with my mission and my values and all that stuff. But I'm also working on A, B, C, D, E programs, right? Like, we all have so much workload and tasks. So when we're going to partners and wanting them to work with you, you need to look at their capacity and try to not overburden them, because that will really, it makes a partnership difficult if it feels one-sided. So one thing that we try to do is to see how we can build the capacity of our partners. And that could come in the form of personnel or workload or funding, equipment, supplies, and expertise. There's a lot of different things that you can do to expand your partner's capacity so that they can work with you effectively to serve your target population you've identified.
Matt, there's a couple of comments in the chat.
Yeah.
I'll share with you quick. Greg says one thing he would add to the capacity is the ability to travel or meet your client.
That's a great one. Being with the community in person, that's great. Thank you.
And then Elizabeth also said mental health behaviors and planning funding, that is what is needed with mental health. Medicaid can help those people to integrate educational technical skills, recover from past trauma. That's why the Department of Human Services needs to help with Medicaid process of mental health and recovery.
Yeah, that's right. Thank you. Thank you for adding those comments. All right. So I'll now sort of walk through these 4 steps and what we did specifically with the Tooele County Jail. And so to start, our priority was to reduce the risk of overdose among individuals leaving incarceration. And with that, reduce recidivism as well. The capacity over the past 5 years, we've kind of bounced around roughly between 3 to 5 staff. And pretty much all of the funding for our staffing has come from grants. And so as many of you likely know, there's a bit of, I almost just made up a word there. It's kind of volatile, as you know, funding comes and goes. And so your capacity, our capacity has varied over the years. So if you're looking at our programming, the whole thing, everything that we've done or tried in the jail, this is it. And I'm going to break down and walk through these things chronologically so you can kind of see how this programming came to be, and what pieces of this programming were crucial for it to be successful. And like I said, I don't want you to think of this and be like, wow, this is amazing, this is perfect, this is everything. Like, there are still improvements to be made, but the changes that we've seen since we've started have been really dramatic, and I think that they're impactful. Okay, so we started off with naloxone. We wanted to reduce overdose. Naloxone is an opioid overdose reversal medication. So if someone overdoses on an opioid and someone administers naloxone, they have a chance of surviving that overdose. So in each of these slides, you're going to see partnership building components, and it's going to be broken out by priority and capacity. And this is referring to the jail's priority and capacity, unless I write where USU expanded their capacity. So this was not a priority for them. This was not a priority for them at all in the beginning. We tried to expand their capacity through staff training, through connecting them to naloxone, through both the Tooele County Health Department and also Utah Naloxone. And we created some educational materials for individuals who are leaving incarceration as far as what naloxone was, how to access it, things like that. It's important to note that, like, how we got in the door here was because we have a really wonderful coordinator. Her name is Melissa, and she went to the jail in person. It's kind of like what that comment was like, referring to the importance of going in person and meeting people. She went in person and just connected with the jail commander there. He was a high school coach, and so was she, and so they talked about high school sports, and connected on a personal level, and that allowed us to kind of start this relationship and this partnership with the jail. So this part of the story to me is the most interesting, because as I mentioned, naloxone and substance use disorder treatment was not a priority of the jail. But then something unfortunate happened. There was a momentum shift, because in the Tooele County Jail, there was an overdose. And the Sheriff Wimmer, that was the first time that had happened since he had been sheriff. And it opened his eyes to the fact that someone with a substance use disorder is not just a person making bad decisions, that it's really a disorder. And that impacted him, that instance. And so what happened there was a change in priority, right? That experience started to change the priority. And the first thing that Sheriff Wimmer wanted to do, what his priority was to reduce stigma. So reduce the stigma of his employees, some of them had towards individuals who had a substance use disorder. And because we had gone to the jail and said, hey, we want to do naloxone training for you, they knew us as an agency that could be involved in this, that could be trusted with, carrying out his initiative. And so what he wanted to do was a training. And so we organized and delivered a summit. This is a 2-day first responder summit covering a variety of topics related to stigma reduction and harm reduction approaches and things like that. And the Tooele County Sheriff's Office also, they participate as a financial sponsor and summit planning and made it possible for their staff to go there. And now it's become an annual thing that first responders in Tooele County count on for their their continuing education and things of that nature. I think that what was really powerful here too, though, is, Sheriff Wimmer sort of had this personal change in priority, but he also spoke at the summit, and he got up and gave this great little speech. But part of it, he said, "I'm convinced that you cannot incarcerate away addiction." And that was huge, because that was an organizational change in priority and shift of which direction he was wanting to go in corrections, and also his field officers. So after that was established, we had gained more trust, and my former supervisor, Maren Voss, she developed a curriculum. She called it the Peace Curriculum. And really, the Peace Curriculum was about teaching mindfulness strategies. And the jail did not have their priority at this time is they did want to expand programs to inmates. Right? They weren't specific on which programs those were, but USU developed this curriculum and delivered the curriculum in the jail, and that was something that the jail appreciated, right? Because we were bringing in that capacity to do that. And again, growing that trust of, hey, we're here and we know that you want to provide programs to the clients you're serving, and we can do that. You can see there, though, that that program stopped occurring in the jail in 2023, and that was because of a loss of funding. Okay, so in 2022, the jail came to us again, and they told us, hey, we had this meeting with the Sheriff's Association, and they told us that we need to start providing medication for opioid use disorder. So if you're not familiar with that, when many people go in for substance use treatment disorder, there aren't very many substances that have a medication that can assist them in their treatment. But there is several options for people with an opioid use disorder specifically. And the Sheriff's Association told all the sheriff's offices throughout Utah that they needed to start doing this. They needed to be able to provide MOUD in the jail-based setting. So again, because of this history we had started building trust with them, with the jail. They came to us and they said, we just got this mandate, essentially, and we need help figuring out how to do this. And this was great news for us, because in those early years of 2021 and 2022, when we were trying to get programs going in the jail, there would be periods where we didn't hear back from them for months at a time. They're very busy. They have a lot to do, and it wasn't as high of a priority. So when this happened, again, a new priority shift, right? Okay, we need to be prepared to provide medication for opioid use disorder in the jail. Also around the same time, the jail commander retired, and there was a new jail commander who came in. And because Sheriff Wimmer had this change in priority of wanting to serve people with substance use disorder, I believe he selected this individual who has been absolutely incredible to carry out this vision. And the vision of this new jail commander his goal is to end intergenerational incarceration. That's what he'll say all the time. And he's very invested in getting people services. In fact, when he was the jail commander at Utah County Jail, he worked with individuals who are incarcerated in his jail to come back and develop a group substance use treatment program. This is a man whose priorities, really aligned with us. And when we saw that, we kind of smothered him. You know, we try to take advantage, because as soon as we saw that priority switch, it's like that's when the timing aligns, and you really got to move so that that momentum doesn't die out. And so this was all very new, you know, providing medication for opioid use disorder. And USU does not provide medical treatment, but as far as building up the capacity of the jail to provide this service, we wrote a grant for them, and they were able to receive that funding. We also were able to contact some of our community partners to help us develop a medication for opioid use disorder protocol. And we met with their medical staff at the jail and helped them understand what this could look like. And they adopted the protocol as something that they would use.
Matt.
Yep.
Maybe I'll have Elizabeth, if you don't mind coming unmuted, Elizabeth, and sharing what your comment in the chat says. That would be great.
Okay. I was talking about this organization in Puerto Rico to this day. I mean, I think they started like 1970s, and to this day they work with the people they want to get off drugs, heavy drugs, dependencies. And many of them have become pretty much heroes, the ones that have graduated with their program. And it has continued helping the Puerto Rican people because the philosophy there is the structure. Most of the time, drugs are not used to complement. You just had to like stop smoking, plain turkey. That's the same thing. It works with this. So this is something that build up the mentally, the conscious, how we can heal ourselves. And I've seen people that have recovered and never used drugs again. Heroin, it was their choices. Now that we are facing all these cuts, and there's some stigma in our societies, because as I'm listening to this conversation, I live in Washington, D.C. I have seen advocacy in Baltimore. I attend classes there as well. And what they want, especially the ones that opioids, they want to fix something to take something. And it, two wrongs doesn't make it right. So I think building up mentally and physically, knowing the urge and know our own system, people can recover. And that's the technique they use. And a lot of psychologists and people talking,
Yeah,
so that we are starting. I volunteer for this organization in DC. I do only volunteer work. I do not work. I am ordained. But that's what I help people. So we connect them together to, especially the person that was talking about, this is something, some studies that he wants to integrate in his planning and help people.
Yeah.
And also alcohol, because alcohol is also like for veterans, when they lose it, they become alcoholics, they become homeless, and it's proven facts. The integration programs work.
Yeah.
Thank you.
So, thank you for your comments. And really the gold standard treatment is to offer medication for opioid use disorder in conjunction with other therapies, other medication based therapy. And our goal of this was not to, force anyone into medication for opioid use disorder. The goal is to give patients the option, because in jails, they don't have the option. You don't have the option to choose their treatment pathway. And the reality is, yes, some people can stop without medication for opioid use disorder, and they do. But also, it is a great and safe way to bridge people into that long-term recovery. It's been very effective and proven. So in conjunction with medication for opioid use disorder, we introduced peer support services, which, in a nutshell, if you're not familiar, individuals with lived experience with substance use disorder who can go in and work with individuals to help them through the recovery process. And they don't necessarily do things for them, but they help them to receive education. They help them to set goals. They help them. I think one of the biggest things is support them through empathy, which is really big for recovery. And at this point for the jail, their priority was to reduce recidivism and reduce overdose. And they didn't have the capacity to provide peer support services. But at that time, we had grants that could pay to have peer support specialists come into the jail. At the same time as the peer support services, we introduced what we called the exit strategies class. And this was a class taught by one of our USU team members. Her name is Cheyenne Anderson, and she really is the backbone of this portion of the program. Exit strategies was a class that was held weekly, where individuals would come in and Cheyenne would educate them on expectations, what to expect when you leave jail, and what do you need to plan for. So she would work individually with people to create exit strategy plans. And in those plans, Cheyenne would connect them to specific referral resources if they needed them. Such as treatment. She was going in with the jail, she was going into the courts whenever her clients who were attending the exit strategies classes, she would go in there and she was very involved. And so in talking about the priority here, the jail was now fully on board, with preventing overdose for people. And that was shown because, or one way that was shown, the local judge actually started reducing people's sentences if they completed the recovery strategies, which we called exit class. If they graduated that and had an exit plan, they could reduce their sentencing. The capacity for this, we were still paying Cheyenne to be in the jail and delivering this wonderful program and, helping with the workbook and all that kind of thing. And the jail was supporting us through, scheduling and making that available and all that sort of thing. The final component of this was a RISE group treatment program. This was a program that was co-started by Tooele County's current jail commander, Lieutenant Darren Durfee. And because of the partnerships that he had with the Utah County Jail, he was able to bring that program over to Tooele County as well. And so RISE was actually able to expand the capacity of the jail by having some of their staff come to Tooele and start this program. And USU supports them. And then, of course, the jail is invested by, scheduling the rooms for them to meet in and offering any support that goes on with providing jail-based group programs. Okay, so all of this culminated in earlier this year, we were able to help the jail continue their funding for this type of programming. And then the jail used that programming to hire Cheyenne, our USU employee, and to make her the SUD treatment manager in the jail. She is a Tooele County Sheriff's employee. And it's pretty incredible, where they've come and how their priorities have changed over the past 5 years, and their willingness to use their grant funding to dedicate it to this. Cheyenne is a peer support specialist herself. She's a substance use disorder counselor. So she is continuing those peer support services, and under her new license as a substance use disorder counselor as well, into developing treatment programs for individuals and things of that nature. Right now, we're very proud of this program and where it's come, but we're still very invested and anxious about its continuation, because nothing is solid or confirmed. But that's what we're working on now. Exit strategies was really our main program in the jail. And so I just wanted to point out a couple of those outcomes because I think it's interesting. Over the couple of years that it had been implemented and data was collected, we had a weekly average attendance of 15 to 20 people. People really valued the class. And then recently, the jail actually looked at individuals who had graduated the program, and they were looking at their rearrest rate. So the recidivism rate for people who had graduated from exit strategies was 3%, which again is, comparing that to Utah and the national, which is much lower. Obviously, this is very new data. People who have left incarceration haven't been out for that long, but it shows that this is a very promising program, and also just having any type of community reintegration and substance use treatment program in your jails, I think, is highly valuable. We asked participants of the exit program to give their feedback, and this is just a snapshot of 5 answers, and you can see that each one starts with Cheyenne. And again, Cheyenne Anderson is really the backbone of this program and implementing it. And it was so valuable for them to have a peer support, someone who had gone through they're going through right now, and help coaching them and mentoring them through this process. So you have great stats like this, and it's great to be able to report, the recidivism rate so far for these individuals is really low, and that we had great attendance and people liked the class. That's great. But also it's really impactful to me to see this type of thing. And this was one of the quotes from one of the participants, and I find it deeply impactful. And they said, "The feeling of not being alone while incarcerated helps build better character and the willpower to want to change. Sometimes knowing that there is someone there makes all the difference in how hard a person will try." And so we're hoping that this type of model, obviously each jail, each locality will be unique, but can implement something like this. Are there any questions?
I just wanted to ask, I know with other substance use programs, we often run into stigma issues, and I was just wondering if you have had any barriers due to stigma in the community or stigma with the people you work with or any sort of things like that.
Yeah, I mean, definitely a lot of stigma, I think, in the first responder community, and they're really dealing with the brunt of this issue in the community. And that's why one of the things we had tried to do in the first responder summits I mentioned was some stigma reduction. I think one of the biggest things for stigma reduction, honestly, has been the fact that the jail staff have worked with Cheyenne, who is a person in recovery. And now that she is a employee, like, that's the biggest way to break down barriers, is really just partnering, inviting people from the community to the table so they can interact with these different partners, I think is really important, and giving them a place of power and decision making to reduce stigma.
Yeah, that's really amazing that you guys were able to get Cheyenne in with the jail as like an employee. Like, I feel like that should be more of a standard thing across the board for jails to have that sort of an employee, but that's really cool.
It was a hard process because the background check kind of stuff, but the jail was really willing. Like I said, their priorities changed, right?
Yeah.
And they became dedicated to this effort as well.
Yeah, that's really cool to see. We're just gonna leave a few more minutes for questions. If anyone has anything, you can drop it in the chat or you can just come off mute really quick. But yeah.
So technically, is the program that, let's say the program that Cheyenne is running right now, is it only in that Tooele jail? Like that one
Yes.
specific jail? Okay,
Mhm.
okay.
Yep.
Do you think it
There
could
are,
be expandable to like multiple areas, just like even more jails? I mean, let's say there would be the funding and like the people for it. Do you think it would be a program that could work just like statewide or just like even nationally?
yes, yes, I do. There are a couple of jails in Utah that started about the same time as us, but do something similar. But I think it's very possible. There, and one reason I'm hopeful is one, it can be very simple. Just the fact of having like a peer support specialist involved is really like one of the key things here, right? But also um, the funding that we've received for this jail programming has been through the opioid settlement funding, and so that's a more secure funding stream. So if the counties are willing to use that funding for this purpose, you know, it should be there, right? It's not as volatile. It's not a federal grant. You know, it is funding that's supposed to be dedicated each year for, you know, overdose prevention.
So you answered my first question, Matt. Great presentation, by the way. I appreciate that. And the success that's been out there is amazing. That's really cool stuff. My first question was, are you using the opioid settlement funding, which sounds like you're. The other question I have, my mind goes to what kind of data you would need to be able to present this in a way that places will go, well, duh, this makes sense, right? It's your recidivism rate is a lot less. People are coming out rehabilitated, which is the goal of, I mean, theoretical goal of incarceration.
Mm-hmm.
But I wonder if you said there's a couple other jails that started about the same time as Tooele. Is there a way to combine data from those other jails as well as the Tooele County Jail to be able to look at it and say, not only did it work for us, maybe Cheyenne's an anomaly. She probably is. Maybe she's, but it also worked in these other 2 or 3 jails. So that says Cheyenne wasn't at all these places. So it has to be something that works across the board. So it would just be curious what kind of data could be compiled to say, and this program works, present it to those legislators, because as you look at that ongoing funding for your area, but also for other jails around the state, or like Shana says, across the nation, is there data that you could compile that would say, this really works and let's move this forward?
Yeah.
So anyways, that's more of a question than a thought or an answer. But I'm just wondering what kind of data would be necessary for legislators to kind of take note of this successful program.
That's a really good question. And honestly, it has been really hard because it's a protected population, right? So as far as like getting permissions, I tried to do something through USU. It was pretty hard through like the IRB process begin because they're a protected population. As far as getting the recidivism rate, that was very easy to do once I got connected to the right people. All it was working with the jail IT to, you know, essentially add a variable to their data management system, saying whether they'd graduated the program, and Cheyenne just worked with them directly and said, yes, this person has graduated, or this person no. But as far as across different jails, I think they would just have to do something similar to be able to calculate recidivism rate.
I was going to say, the recidivism rate's kind of that quantitative data, right? What's the recidivism rate? How well does it really work across multiple jails? And then the qualitative part being those stories you have, where it says Cheyenne did this, X, Y, and Z. And I wonder, because you could de-identify I'm thinking out loud, so people that know more about research, speak up, but you could de-identify everything because recidivism rates de-identified, those individual stories, and you combine that qualitative and quantitative data and say, here's what people are saying, here's what we're seeing rate-wise, and then see if you can find someone that could be an advocate for you on a legislative level to say, here, I'm going to present this to you, take a look and see what you think. So anyways, more thoughts than questions or answers, but just maybe something to consider.
I'll just add one more quick thought to that, Kurt. The tricky thing, right? If you really wanted to prove impact, because we can prove or we can show that our outcomes are good, that we said we want to do this thing, and then we're able to show that we did it, right? But showing impact is another part of evaluation. It's a separate piece, and that would probably involve on the overdose end, right? Following up with people, which would be a pretty serious IRB process to even if you of course you would de-identify it when publishing the data, but IRBs are very, very particular about even allowing you to reach out to people and asking them, hey, how's your recovery going, for example. But I mean, in a perfect world, that's the gold data, right? Which is why we were so excited about recidivism rate, because that was pretty easy to collect, and we didn't have to talk to anybody. We could just see if they had a rearrest in the system. So, but yeah, perfect world, you could track people down and ask them. Excuse me.
And also, Elizabeth has her hand up. Go ahead, Elizabeth.
I think you're on mute, Elizabeth. I think you're on mute.
Okay. I was just curious because I know you're talking about jails, and I put a question over here. How you determine who determined the intakes of that person that you're trying to help?
Oh, sorry, Matt. I think you're on mute.
Yes, I am. Thank you. Sorry, I've done that a few times today. Yeah, so when someone gets booked into the jail, as of a few weeks ago, I think it's now mandated by the jail that everyone has to receive an assessment. So it's the medical staff in the jail. And then Cheyenne is just helping to make sure those assessments are being done. But it's the jail medical staff that do the intakes.
They have a doctor there?
Yes, they have a doctor, but in rural small jails like that, it's a doctor that oversees multiple jails. And so he's not there physically all the time. They have a head nurse who runs the medical program, and then he's on call. So if if they have patients, they call and ask.
Okay. The reason why I just picture, like a person like me, I never been in jail. I'm a good standing citizen and I help the needy. But I supposed to do a surgery on Monday, yesterday. I mean, the day before yesterday, and I had to cancel it because for pain, they have sent me oxycodone. It's in my chart that I cannot take that drug. And that's why I had to pay always out of my pocket. It will be my responsibility to take it. The insurance will not pay for it. So imagine I was thinking, because this person was busy, the administrative. The doctor did not see it. She overlooked. And not only that, she overlooked other stuff. And I remember we going back again to this law. I'm not sure if you knew about when people were dying because saline, they were allergic to salines and they die. And then it came a bill that they had to ask you what if you're allergic to any substance, if you're pregnant, blah, blah, blah. So that's what I'm asking you here. Who determined if this person is, and you said a doctor, so.
Yeah, the medical staff that's contracted at Tooele County Jail handles all of that.
Yeah, because people can die of that opioid,
Oh,
even
sure.
oxycodone, they can die. I could die, but because they have given it to me for pain before surgeries, and that's why I noticed when I used to have that, I just pray that I don't die that bad.
Yeah, no, it's
So
very
thank you
important.
You answered the question. It's great. Thank you.
Great. Yeah, thanks. Thank you so much for inviting me to do this. I appreciate it. And anybody feel free to reach out if you have questions. I'm sure Shane will share my email. Thank you.
Yeah, thank you. Okay, perfect. Awesome. So this is a CAPTA referral. The age is 7 months and the living situation. The child currently lives with her grandparents due to her mother's ongoing substance abuse issues. The grandparents have taken on the primary caregiving role to ensure the child's safety and well-being. And then the initial concerns are the child has shown signs of developmental delays, particularly in emotional regulation and physical coordination. And there are concerns about her ability to remain calm during routine activities and engage in balanced physical movements. So the primary area of concern is her physical development. She is beginning to show interest in reaching for objects, but tends to favor one hand over the other. She has started to roll from tummy to back, but struggles with rolling from back to tummy. And then emotional regulation. She often becomes distressed during diaper changes and other routine activities, indicating challenges with emotional regulation. Communication, she is starting to coo and babble, but does not consistently respond to vocalizations from caregivers. And then as for social interaction, she enjoys playtime with her grandparents, but has limited interaction with her mother due to the current living situation. So our goals and barriers, playtime movement, structured play sessions that encourage bilateral movements such as reaching for toys and rolling exercises, routine and rituals, establishing consistent routines with the mother, including feeding, playtime, and bedtime rituals to build confidence and security. Vocalization, interactive play that encourages vocal responses such as cooing and babbling with familiar adults. Okay, cool. And we're just gonna stay in the big group today. So I'll just read out our discussion questions and then we can get started. So the first one is, how can caregivers encourage and support bilateral movements during playtime to ensure balanced physical development? And then what routines and rituals have been most successful in preparing the child for transitions to her mother and other social outings? And then lastly, what are some areas of development grandparents should monitor for the future because of drug exposure? So we're just going to get started with the first one. How can caregivers encourage and support bilateral movements during playtime to ensure balanced physical development? So does anyone have thoughts?
I should probably have thoughts since I'm a physical therapist. But, the thing with any kid really, but especially kids if they've had any trauma or big changes in their lives, they're going to go to whatever's the most convenient and comfortable. We all do it, right? When we get stressed out, we have our comfort foods or whatever we do to kind of de-stress. So kids a lot of times will do that. So sometimes that'll mean they're just using the one side. I always tell parents in situations like this to find, I call it their super motivator. So whatever is the most motivating for that kid. So maybe it's a fruit snack, or maybe it's a book, or maybe it's a hug from mom or a song or something like that. And I tell the parents just to use that when the child is doing what they ask them to do. So if, say the kid's always reaching with that right hand, doesn't want to reach with the left, obviously we're going to present it to that left hand. Likely the kid's going to reach across with the right and try to grab it. But that motivator, that super motivator, can be used that they reach across and they might get whatever the object is with the right hand, but they don't get that motivator. But if they reach with the left or even attempt with the left, oh, here's that fruit snack, or here's the hug, or here's the song, or whatever you wanted to hear, and really start retraining. Because it sounds like, just from the brief history that you gave right there, Shayna, that it's probably the trauma of being separated from family or whatever trauma has happened. And now they've kind of gone into that comfort food mode where it's easier to use my right hand, so I'm just going to keep using it. The problem is that over time, they develop that movement pattern to where they don't use their left as effectively, even though initially they may still be able to. So I'd use a super motivator type of thing. Whatever they really want, give it to them only when they're doing the activity and using the hand that you want them to use, or only completing the activity they want in the way you want them to do it.
Yeah, that's really smart, especially with like finding something that they really, really want to have. So
Well, the hard thing about that is that when kids start crying a lot or they get really fussy, a lot of times we give them the thing they want most, so it becomes common to them, so it's not as motivating. anymore. So I always tell
Right.
parents, if they love fruit snacks, doesn't matter how hard they're crying about their kid, their brother, or sister knocking them down or whatever it is, don't give them that. Give them something in place of that, and use this only when they're doing that activity you want them to do. That's a hard thing to do for parents that are overstressed, though.
Yeah, for sure. That's really smart. Does anyone else have any other thoughts with the bilateral movements side of things? Oh, Elizabeth? I think you're on mute.
Okay, I am talking about as my own testimony. I think there are sometimes when we're serving a patient, we should sit down and try to open the dialect, because some people think that when you are a caregiver, it doesn't means that you have to cook, clean, and do all these things for this person, because unless that you as a Medicare nurse know what is the needs of the patient. So it is very, for us to, it's a process when as a caregivers, we need to request always what the nurse assessment is, because if the person cannot write, or the person, how you expect to go to the supermarket if she cannot write, or that means she cannot use the hand or the fingers, so how she's going to pick up the needs. So grocery shopping list, that person will have to learn all these things, and it could be very aggravated, especially if we are dealing with a person with all the mental disorders. So it's not that some people have taken this, what I have seen up there, because that's not my job right now, that I don't do that, but I do it in other areas that the person needs, which is with mental guidance of people with all these disabilities. It's very frustrating that you give a paper to a patient and then that person cannot write it because cannot use the fingers. So as a caregiver, we have to think about these little areas that sometimes they overlook. And also with the case workers as well too, and the nurses. And sometimes when caregivers, they have one nurse coming every month. That's what the EPD waiver of Medicaid provides to the people that they qualify for that services. We're not talking about budget cut fundings. We're talking about this person has a caregiver. They, as providing that service, is getting paid to do a service too. And it's the caregivers also needs to get these classes, mental classes, to care for their health as well, because it's like a caregiver is not only doing thinking, physically working, and also thinking for somebody else. It's very difficult job. And we had to pretty much, we cannot keep guessing or guess what the other person is thinking. So every month, the caregiver should give a calendar and do this and do that in order that person also have time for their personal care. He talked about the peer specialist. That's pretty much some of the caregivers has to become too. And that's the only way that we can really help those people to get better, or to give a better services, and also to keep happy and fulfilled.
Yeah, I totally agree. I think it's important for to think about the caregiver's well-being as well as the kid. So, yeah. We can just move on to the second question. That's what routines and rituals have been most successful in preparing the child for transitions to her mother and other social outings. So if you guys just can think of anything that you've experienced or worked with anyone, like just routines and rituals to help with those transitional periods. Oh yeah, go ahead. Yeah.
About the rituals, this
Mhm.
is something very interesting about the caregivers. Some of the patients or children, even children, family, I mean parents, they have certain times where those routines become setting boundaries, and when those rituals becoming something that we must do in order to achieve we could be teamwork on an activity. It could be going to the movies with the grandchildren, our children, and educating about how important is self-care as well. If you cannot take care of yourself, it's okay. We are here to help you until you get there where you can do it all by yourself. Did that make sense? Especially with children. I'm an orphan. My mother died when I was very young. And then not only she left me, she left everybody else on my family and another child that that he adopted from her sister, that she died having a child. So she left 12 orphans, and I was an orphan too. So all my life, I thought about what happened to him. And I recently found him, but he's dead. But I found his brothers and sisters, which it brings me a lot of pride. So the rituals are one of the keys of happiness and setting goals and achieving them. So that's very interesting that you put it here because I think I live for that. Thank you.
Really, and I think teaching about self-care from like a younger age is really important too. Okay, we might move on to the third question then. What are some of the areas of development that the grandparents should monitor for the future because of the drug exposure?
I think there's multiple areas of development that the grandparents should monitor in the future. I think
Mhm.
one is just the physical development, which it seems like they're already doing, especially when they're bringing up those concerns of the bilateral movement and whether or not they're using like both of their hands to do things. I think emotional development is also a really big thing. Emotional and communicative. I know the child may be really young, but I think there's still lots of things that children do to just communicate their feelings. So in this certain situation, if they're kind of monitoring those three certain things, I think it should go well. I mean, there's also like government programs that will help them monitor as well. Like there's early intervention and there's certain, things that will help them. But I think if you just kind of monitor, like especially emotional and communicative, because I think early on, when children start to experience those sorts of traumas, especially very early, like the child in this case is pretty young, but you'll just want to kind of monitor how they're communicating themselves and how they're communicating to others and what they want and what they don't want. So I think it's important.
Totally, I agree.
One of the other areas is the sensory area. A lot of times kids who are exposed in utero end up with either hyper or hyposensitive, really sensitive or really lack of sensation, whether it's with pain or with touch or with texture, any of that kind of stuff. So that's been something that I've seen over the years. A lot of kids that have drug exposure will end up developing some sensory concerns. So that may be something to keep an eye on.
Totally. Do we have any other thoughts on the third question or really any of the other two?
I was gonna say on the second question too, I think I'm just
Mhm.
a little confused by like what it's asking. Because are you saying like what routines and rituals have been the most successful in preparing this certain child for? Is that what Janelle is asking in this case? Because
I'm
were there
assuming
like
she,
are there like previous examples that the child has like done where they like didn't like it or they did like it? Because then when I'm reading the case, I mean,
didn't really mention.
because the child often becomes distressed during diaper changes and other routine activities, indicating challenges with emotional regulation. But I necessarily couldn't really think of like a routine or ritual that would be really successful for kind of preparing a child for the transition to their mother. I think just having a positive association with that transition to their mother and just not having it become a negative association when they're handed off to their mother and between their mother and their primary caregiver, because a lot of the times children will start to like associate negative things with kind of like the handoff or some of the routines that they start doing. So yeah, I genuinely don't know. I mean, even like the suggestion of like going to the movies or playground, like the playground would be perfect for this child because maybe they just experience, especially because when you go to a playground, you could even support like those bilateral movements and start doing things towards that and working towards that as well.
I think saving like more of the fun activities for when you're going to her mother, and just kind of making it more of like a special event might be a good way of doing that, like you were saying with the playground and the movies or whatever else the kid likes to do, making sure they're doing it with their mom a lot just to keep that relationship good. So I think we're pretty close to time, so we might just go ahead and wrap up. Next month, our session will be on the Journey of Hope, Utah, and we're gonna have Shannon Cox come, and that will be on June 11th at 12. So we're excited to see you all there. Have a good rest of your day.